Good afternoon, everybody, and thank you to the organizers for again having this biannual meeting. This is one of the most interesting sessions, which is trying to assess how people in training present cases. And so I'd like to invite my uh, co-examiners, Dr. Ghansyam Biswas, Dr. P.K. Mishra from Varanasi, and Dr. Virender Tiwari from Mumbai. And maybe we can have the presenters starting the case presentations. Okay, there. All right, so I think we have three: Dr. Shreyas, Dr. Vama Agarwal, Dr. Amol Rathod, Dr. Tejas, right? So how are you going to be presenting? You'll be presenting one by one, or how is it going to be? Okay, all right, let's start. So before you start, just give us a background of what you are doing and what are your disciplines.
Sir, we are DRNB medical oncology residents. Myself, Dr. Shreyash Shelke.
You are third year, you are,
Third year, sir.
and you are second year. Okay, and you're all in Madok.
Yes, sir. At PD Hinduja Hospital, Mahim, sir. PD Hinduja Hospital, Mahim.
Okay.
Good afternoon, everybody. Thank you, the organizers, for this opportunity and the exams. So my case is of a 65-year-old male who is a resident of Ghatkopar. He's a clerk who is retired currently, who was symptomatic in view of cough and chest discomfort or pain since 2 months. The cough that was initially dry, then later it progressed to become productive, which was whitish to mucoid through the day. There was no hemoptysis or postural variations. He received multiple courses of antibiotics to a period of 2 months, but there was no much relief. It used to respond to cough medications, like cough syrups. The chest discomfort was in the form of a heaviness and a pruritic chest pain, more in the right upper half of the chest, which used to aggravate on coughing, and it was relieved on sleeping on the right, or lying on the right side. There was no fever, hemoptysis, breathlessness on exertion, wheezing or chest discomfort or tightness. There was no chest pain on exertion or angina, syncope, orthopnea, paroxysmal nocturnal dyspnea, swelling of the legs or puffiness of the face, and there was no history of decreased urination. There was no history of weight loss, fever, night sweats. There was no history of backache, focal neurologic deficits in the form of asymmetry of the face or inability to move the limbs, or giddiness or seizures. So the patient's current treatment history, he had consulted a pulmonologist who advised him a CT scan for the evaluation of his chronic cough, and a mass was detected on his imaging, and he has also underwent a biopsy of the mass, which came positive for some malignancy. The patient has also underwent a battery of tests like PET CT scan, blood tests, MRI brain and bronchoscopy for the same.
Let's stop here. So, can you go back to your first slide? All right. So, what is the most important history which we need to know?
Smoking. He was a non-smoker, sir.
So that should appear right at the beginning, right?
Uh,
And you have already written that he's a clerk by occupation, but for people like me who don't live in Mumbai, what is Ghatkopar? Is it a village, town, suburb? What is
it's
it?
part of city, sir.
It's part of these. It's part of
Mumbai
Mumbai
city.
city.
Yes, sir.
Okay. And so, what kind of an area is it?
It's a urban area, sir. Urban community.
Okay.
So with this much of information, so this patient has landed up to you. So what would be have been the first investigations?
Sir, one slide of sir history is pending, so just can I complete?
Yeah,
that?
please.
Okay.
Go.
Still left to history.
So
Okay.
in the past history, the patient does not have any comorbid illnesses like diabetes, hypertension, ischemic heart disease, tuberculosis or tuberculosis contact. The patient's bowel, bladder, sleep, appetite habits are normal and denies any addiction like tobacco, smoking, alcohol intake. He has a mixed diet and the family history was not contributory. So I would like to summarize the findings of my case as a 65-year-old gentleman who is a clerk, retired now, complaining of cough and a right-sided pruritic chest pain of a 2 months duration. He is having a suspected malignancy uh, of could be of any origin. My other differential could be pulmonary tuberculosis or uh, uh, atypical chest infection, sir.
What do you mean by atypical chest infection?
So, partially treated lower respiratory tract infection, sir, because he has received multiple courses of antibiotics and it had not responded.
So yeah, can you be more specific?
So, post-viral pneumonitis, sir, or some.
History of 8 weeks, no? So that is good enough time. So
Yeah,
You have a localization, right? If you have a post viral syndrome, it is uncommon for it to have a localization to one side.
yes.
So it is fine. You're suspecting a malignancy, okay. Tuberculosis, all right. Third thing you said was sequelae of some infection. What type of inadequately treated lung infection can cause this kind of symptoms? So necrotizing pneumonia can occur,
Yes.
and if it has not resolved properly, you can have sometimes a complicated parapneumonic effusions or even a developing lung abscess. I do not remember if you had history of sputum production or not.
No, it was there, sir.
It was there, right? So an inadequately treated necrotizing community-acquired pneumonia can go on and you can have such symptoms. What other important group of disorders you need to consider? I agree you are medical oncology trainees, but still when you see a patient, you have to see in totality and not just the treatment part, right? So what other thing you should consider? And that can occur in people who have received prior immunosuppressive therapy. One group of infections.
So, pneumocystis, sir.
anything else? Which you see saw more common during the COVID times?
Fungal pneumonia, sir.
Correct.
Fungal.
So fungal pneumonias can present like this, right? And they can often present as mass-like lesions. One more important differential diagnosis. They can present with cough, they can present with chest pain. It is not an infection, it's not malignancy.
Sir, autoimmune inflammatory conditions, sarcoid.
Sarcoid typically doesn't have chest pain, but autoimmune is fine. What else? Well, I mean, refine it a little more.
So, interstitial lung disease, sir.
So systemic vasculitis,
Okay, sir.
especially GPA. They can present with mass-like lesions, localization and all that. Okay.
So any other history, so that can probably take you into sort of malignancy, so which is very characteristic. At times it's important. So when you talk to the patient, then probably it's from the history only, not examination. Or you ask a leading
Sir.
question, so either to the patient or the patient attendant.
Any past history of radiation, sir?
You ask for hoarseness, so
Oh,
that helps you
yeah.
in diagnosis.
Yes, sir.
Recent change in voice or hoarseness
Yes.
of voice, no?
So I think history, it is like we are rule out everything, but we have to go in much depth. So it should be appears realistic. because everything is ruled out, maybe some off and on fever and off on, so that maybe it should be realistic, more, it may be more realistic. So this thing can be ruled out.
So I would want to proceed with the examination. The patient was examination in broad daylight with natural lighting. The patient was conscious, cooperative, oriented to time, place and person. The pulse was 90 beats per minute regular in the right radial artery. All peripheral pulses were well felt. It was regular, no radial or radiofemoral delay. There was no special character. The blood pressure was 110 by 70 millimeter of mercury measured in the right arm in the sitting position. There was a respiratory rate was 20 per minute, which was abdominothoracic type and regular. The pulse oximetry SpO2 was 98% on room air, and the temperature was 98 degree Fahrenheit measured in the axilla. The height was 171 centimeter with a weight of 68 kg, with a BMI of 24 and a BSA of 1.6 meters square. The patient was averagely built, moderately nourished. There was no pallor, icterus, cyanosis, clubbing, lymph nodes or edema feet. The skull, skin, spine examination were normal, and there were no smoking stigmata seen. The findings of the general examination were essentially non-contributory.
Non-smoker, right?
Yes, sir.
So why were you looking for stigmata of smoking?
Sir, patients are often
Patient might
conceal
have
the
given the
history.
wrong information.
Yes, they often conceal the history, sir.
Is this the only case or you have another case after this?
One case only, sir.
This one only?
Yeah.
Alright, let's assume this patient said that I used to smoke but I quit. What is the way of getting an accurate smoking history? What will you ask?
When did he quit?
Alright, he says I quit 2 months back when I started developing symptoms. See, why is smoking history so important?
Major risk factor.
No, risk factor apart, does it influence your management at some point of time?
Yes.
In what way?
The histology.
Histology and then further?
So outcomes for smokers are universally worse than non-smokers.
Okay, histology, the next step?
So targetable mutations.
Right, alright. So that is to still a very large extent influenced by the amount of smoking exposure, none or heavy or light or moderate. So he said he quit 2 months back. So what is your next step of finding out the smoking exposure?
So we would calculate the pack years.
So what are you
of
going to
smoking.
ask?
So how many cigarettes per day he used to smoke? What was the type of cigarette he used to use?
That's okay.
Then duration in years, sir. And
Right.
we would calculate the smoking pack years and the smoking index.
So he will tell you before this I used to smoke 5 cigarettes per day and I have smoked for 15 years.
7.5 pack years.
Now what is the catch with this? And I am telling you by past experience of 15-20 years in trying to elicit smoking history. So people tend to underestimate their smoking exposure when asked upfront, right? So they will say, before this I used to smoke 5 cigarettes a day. But if you ask, what were you smoking at the peak of your smoking? They'll say, I used to smoke 1.5 packs or 15 BDs or 20 BDs per day. And the other thing is, you will ask them how much smoking exposure you have had, they'll say 15 years. But that is an underestimate. When you ask at what age did you start smoking, then will you get the answer. People will tell, I started smoking age of 20 years. And somebody is 66 and has quit 2 months back. So your smoking exposure is not 15 years, it is 45 years. And that makes a huge difference in your assessment of the probability of harboring an oncogenic driver alteration were this to turn out to be adeno. Okay?
Is it only oncogenic driver mutation that is important or something else? Because that only will come in advanced disease, and today they are coming into an adjuvant. Otherwise,
So small cell lung cancers are also common
Okay.
in smokers.
suppose there is a operable lung lesion, then
Uh,
so operable lung lesion in a smoker and a non-smoker,
Sir,
or a chronic smoker. So
the fitness for surgery also
yes,
depends
so
on
that's
that.
that's so important. So you might get a small lesion, but the patient can't go through the knife of.
Yes.
Okay, let's go on.
Because of the findings of respiratory system were contributory, I would want to first elicit the respiratory system, examine the respiratory system. The upper airways were normal, the trail sign was negative, the trachea being central. On inspection, the chest was symmetrical, elliptical in shape, with the respiration was abdominal thoracic type, with the transverse diameter more than the AP diameter. No scar, sinuses, dilated veins, bulge or seen in the chest. On palpations, the findings of the inspection were sorry, I missed the apex beat, sir. On the apex, impulse was appreciated from the one side of the bed near the left nipple. On palpation, the findings of inspection were confirmed. The trachea is central. The inspiratory and expiratory ratio is maintained. The respiratory movements are normal in the anterior and from behind, and on the lateral examination, the TVF is not decreased on any side. The apex beat on the left fifth intercostal space medial to the mid clavicular line is seen. On percussion, a resonant note is heard all over the chest, but there is an area of clavicular dullness in the right side. The cardiac dullness is present and the liver dullness is appreciated near the right sixth rib. On auscultation, I could appreciate bronchial breath sounds in the right upper zone. Uh, uh, there was increased tactile vocal resonance also in the same area, with normal vesicular breath sounds heard all over the chest. In the examination of cardiovascular system, the S1 and S2 were heard and no murmur or other abnormal sounds. The per abdomen was soft and non-tender, and the CNS patient was conscious oriented with no focal neurodeficits. So
Zones are used in chest radiograph, not clinically. Here you have areas, mammary,
yes,
inframammary, axillary.
inframammary, yes, sir.
Yes, so what is your finding in short?
Sir, in the respiratory system examination, I could appreciate a clavicular dullness and bronchial breath sounds in the supraclavicular and infraclavicular region, with increased tactile vocal fremitus in the same area. This suggests that there is a mass or consolidation underlying that area of the chest. Sir.
So you mentioned about
given the-
performance status or not?
So he is a ECOG performance status 0, sir.
But it is not written. It should be mentioned, I think, because we are going to treatment before that, and we need to see the overall hygiene also. That can be also give clue for the other, like smokeless tobacco, because most of the patient here mix smokeless tobacco and this smoking. So oral hygiene and multiple, we can see the examine the multiple cancer can be present same time. This can be.
Yes. So, sir, I would want to proceed with investigations to confirm my diagnosis, sir. So, I would want to first investigate for general fitness in the form of a CBC, LFT, RFT, sodium, calcium as the electrolyte parameters, with viral markers HIV, HbSAg, HCV, and coagulation profile, PTNR, APTT, bleeding clotting times, and a 2D echo of the chest with ECG.
So Shreyash, so chest X is obsolete?
uh,
Chest X-ray?
no, sir. Chest X-ray can be used, sir, but
Most of the time the patient comes to us, so they will have a chest X-ray in these 2 months. So at least 1 or 2
Yes,
chest
sir.
X-ray they must have, no?
Yes, sir. He had underwent a CT chest, sir. Per the sensitivity specificity for the CT chest, sir, for a suspected lung is more so first I would want to do a contrast enhanced CT chest for this patient.
You'll ultimately do a scan, you will ultimately do a PET scan. But somebody who comes with the 8 weeks history and comes to you, so they will show you a CT scan, but just look at his bag. So there must be a few X-rays,
Yes, sir.
because a general GP who was treating, even a pulmonologist, they will ask for an X-ray first, no?
Yes, sir. And I would also want to first evaluate with sputum studies for gene expert, anaerobic bacterial culture, fungi, and sir, a gene expert on the sputum sample with the culture, and also cytology for malignant cells on the sputum because he is having purulent sputum, sir.
Are you having images?
No, sir, we could not.
So
get
you
it,
have
sir.
one case, you must have image also, it will be help the things. You can have image of X-ray and CT. So because most of the examiners come and want to see the chest X-ray, and maybe your whole Viva finished in chest X-ray and imaging also. Nobody interested in treatment. So if you have one cases, then it should be have all detailed findings.
I agree. So if it is just one case, you should have the imaging presented. I mean, it's not very hard these days. Everybody has smartphones. You can just click an image and put them.
Extremely sorry, sir.
So does every suspected lung cancer or even a biopsy proven lung cancer goes for MRI brain? So when are you going to ask for MRI brain? Suppose now with this diagnosis, so you have a PET CT, you have a CT, you have a biopsy, and you know the type of malignancy now. So when are you going to ask for an MRI? So is it for all, is it for specific group?
So we prefer MRI only when the patient is having T2 or if we are suspecting any nodal metastasis.
So nodal metastasis, then?
So, mediastinal lymphadenopathy T2 and above size, sir, or any systemic features of malignancy, we would want to have
So
an
now
MRI.
there will be two groups. So one is operable. So you want to complete the pre-operative investigation. So MRI can be a part of that because you know the sensitivity for a PET CT for a brain is not good.
Yes.
So that is one part. Suppose second part is a inoperable disease or a metastatic disease. So for metastatic asymptomatic disease, so are you going to do an MRI?
Yes, sir. Still
If
we
yes,
would do.
which are the situations?
Sir, in a small cell lung cancer and oncogene driven lung cancers like EGFR, ALK,
Right.
to
So
decide
because
the
you know
brain
that-
penetrant TKI, sir.
Absolutely. So EGFR, ALK. So in the yesteryear, we are saying that if the patient is asymptomatic, you are not going to do. But even in an asymptomatic EGFR positive, ALK positive disease, so you are going to do a baseline MRI because that will help you in starting or selecting your drug for those situations.
So you have mentioned these investigations. So what is the next step we have after these investigations?
Sir, sir, after the staging investigation at the CT, I would subject the biopsy to special tests like,
You haven't told us the stage.
sir, it's a CT2 N2 moderately differentiated adenocarcinoma of the lung, sir.
Now go
So-
one slide back. So this one slide back.
Sorry,
Okay.
sir.
So the CT report you have said is enlarged right hilar and right sided mediastinal nodes, and the PET CT is right hilar and mediastinal lymph nodes. Is this okay? Are you satisfied with the radiology reports of both the CT and the PET?
Sir, we would want to confirm the N status first with invasive mediastinal staging, sir.
But you don't even know which nodes. Neither the radiologist reporting the CT nor the radiologist reporting the PET CT has mentioned the lymph node stations. What is right hilar lymph node, by the way? What station is it? What lymph node station? Huh? 10 to 14 nahi hai. What you are telling is something else. 10 to 14 lymph node stations are what lymph nodes?
So N1, sir. They are N1.
Correct, if they are on the same side as the primary.
Yes, sir.
And what is right hilar?
So that would be an N2 node, sir.
No. What station is it?
So is it a hypothetical case or a real life case? Then
Real, sir.
then it should not be a problem for you, no?
Okay, can you just enumerate the lymph node stations from 1 to 14?
So one is supraclavicular, sir, bilateral. Two
Also,
R and
also
two
called
L.
as highest mediastinal.
Yes, sir.
Hmm.
2R and 2L, right and left paratracheal, sir.
Upper paratracheal,
Then 3 is prevertebral,
prevascular,
prevascular.
and it can be 3AR, 3AL, or 3P. Next.
Then, sir, right and left lower paratracheal is level 4,
4R and 4L, correct.
and sir, 5 and 6 are para-aortic and subaortic, sir.
Which one is para-aortic, which one is subaortic?
5 is para and 6 is okay.
5 is subaortic and 6 is para-aortic.
7 is, sir, subcarinal. 8 para-esophageal. 9
Inferior pulmonary
inferior
ligament.
ligament nodes.
And 8 and 9 can be again R or L, right?
Yes.
7 is only 7.
Yes.
Now, what is the significance of 5 and 6 nodes?
Sir, they are not visible. They can't be targeted with a EBUS, sir.
Okay, but in the context of staging.
Regional versus non-regional.
So level 5 and level 6 nodes are sort of the only numbered nodes which are N2 for a left-sided lesion and are N3 for a right-sided lesion.
Yes.
For all the ones it is RL, 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 correct? So in a right-sided mediastinal, it is hilar is 10, 11 is interlobar, then you have lobar, then you have segmental, then you have subsegmental, HIL. SS. Okay, so this is right hilar is 10R. Now it is written as right-sided mediastinal lymph nodes. The reporting radiologist needs to mention which lymph node stations. Is it 2R, 4R? And this is not enough. They need to mention ideally a good, perfect radiology report for CT and PET should tell 2R lymph node, 1.5 by 1 centimeter, SUV max 2.5, next lymph node station size, SUV value, size, SUV value, and that is how it is going to help you decide what you are going to do. It is also going to help you decide whether you need to sample these nodes or not. If you find right-sided mediastinal nodes, suppose it is 2R, 4R, 3AR, and they are all 3 centimeter by 2 centimeters, you probably don't even need to sample them because there is a very high probability that they are going to be involved.
Yes.
So this is an incomplete and a unacceptable radiology report.
Yes.
And you have to go and ask the radiologist, please give us this information.
Yes.
Okay. So based on this, what is your stage now? T?
T2, N2, sir.
Okay. So next step?
Sir, we would do endobronchial ultrasound, sir, for non-invasive staging.
So there are no contralateral nodes, right?
No, sir.
There is no distant metastasis.
No, sir.
All right. How is an EBUS going to change your management at this point of time?
Sir, with an EBUS, if we detect a N3 node or multi-station N2, more than 3 centimeters or multiple nodes involved, sir, then it can upstage it to a 3B, sir.
If you find N3 disease, it becomes no. What
The
stage?
management 3B, sir, 3B.
It becomes 3C for all practical purposes. So you find multi-station N2. So then you will not offer the patient surgery.
Sir, we would discuss the case in a multidisciplinary tumor board
Okay.
consisting of medical oncologist, thoracic oncosurgeon, sir, and assessment for pulmonary function test DLCO for eligibility for surgery. After that, sir, we would want to analyze the biopsy specimen for
So
EGFR by
you won't
PCR.
involve the radiation oncologist here?
Yes, sir, radiation oncology also. EGFR by PCR and IHC for ALK without fish, and PDL1, sir. And after that,
So
come
with or without fish means?
sir, with the IHC for ALK and fish are, sir, quite concordant in results. If it's not contributory due to technical issues for the IHC for ALK, we would want to confirm it with the fish. That is what I mean.
So how is an IHC of ALK reported? What report will you get from the reporting molecular biologist or pathologist?
So it's ALK positive, so how will the report come?
So in the molecular report or the histopath report, sir, there is a EML ALK fusion detected in the fish.
So what does the IHC look for? The EML ALK fusion, or what does it look for?
So ALK protein, sir, on the cytoplasm, staining, sir.
So what will the report tell? Any other students in the audience, please? TMH के भी तो होंगे? नहीं, कोई नहीं?
Sushil,
Protein expression positive or negative on IHC only. Staining positive or negative. It's like protein expression only.
Right. So that is one way of reporting. ALK is positive or ALK is negative on immunochemistry. The same immunochemistry can also be reported in another way. It is, most labs don't do it, but otherwise they can also report it as the intensity of staining, 3+, 2+, 1+, and 0. And a typical ALK positive is 2+ or 3+. 0 is reported as negative. 1+, sometimes they will report as equivocal and confirmation by fish. So that is the role.
Yes.
Okay. So your next step. So if you are present in the multidisciplinary meeting, what is your argument going to be for? So let's assume you've done the EBUS and you have the lymph node size is 1.2 by 1.2 centimeters, 2R, 1 by 1, 4R, and the 10R lymph node is 2 by 1.5. And they are all, the 10R is positive, the 4R is positive, and the 2R is negative by EBUS. So what are you going to do next now? And you are sitting in the multidisciplinary meeting which has surgeons, radiation oncologists, and yourself. Neoadjuvant chemoimmunotherapy, and the plan is to do what?
So 3 cycles of platinum-based chemotherapy with
With
nivolumab.
nivolumab. And why not any other drug?
So according to checkmate 816, the PAT-CR rates as well as event-free survival rate is.
so are you looking at a surgery at one point of time? So that is important.
Yes, sir.
So a 65-year gentleman, so if you are looking at a surgery, then your regimen is different. If you are looking at something like CTRT regimen here, so operation is not on the, then you are looking at a maintenance of durvalumab. So you have to decide, so what is your plan, so after your initial treatment. So that's how you are going. So if you are thinking of immunochemotherapy, then you are looking at a surgery. So if,
Yes, sir.
so that has to be decided, right?
Which means that the surgeon has to indicate that yes, this patient is potentially resectable, right?
Yes.
And so what is the difference between resectability and operability?
Operability is a patient factor, his fitness decides that, and resectability is the tumor factor.
Correct. So in order to have a surgery, the disease has to be potentially resectable and the patient's characteristics have to be of operability, right? And this treating surgeon or the person who's going to operate has to say that yes, this thing. So let's assume in this case, the surgeon said, I have no issues operating. So then on the other hand, you have a radiation oncologist who said that no, we don't need to subject this patient to surgery, we can do chemo radiation. So what is your argument? You are going to be involved both ways, right? Whether the patient goes for surgical resection or goes for chemo radiation, you are going to be involved in both scenarios. What is going to be your preference, or what is going to be your pros and cons for each scenario?
Sir, I would prefer surgical and NACT or adjuvant chemotherapy approach with or without immunotherapy because of the patient's fitness and better quality of life parameters and higher survival with surgery and chemotherapy compared to definitive chemo radiation, sir. Because chemo radiation is associated with significant pneumonitis, esophagitis, increased cardiovascular risks, and yes, sir.
So for this patient, remember the EBUS sampling only picked up single station N2,
Yes.
right? It wasn't multi-station N2.
Yes.
Although let's assume that the radiology report was what we wanted, but on sampling it was only one lymph node which turned out to be positive, right? So in that case it becomes single station N2 and non-bulky because the size is still
Less than 3 centimeters.
okay, it's still even less than 1.5. So would you consider upfront surgery for an adjuvant therapy, or would you consider a neoadjuvant approach followed by surgical resection?
Sir, there is no PFS benefit with either of the approaches, sir. But with the neoadjuvant approach, we also get an opportunity to evaluate the disease biology of the pathological complete response rates
So we
and
are
also
almost like
higher
we are
completion
almost
surgery
like
rates.
going the breast way, no? So TNBC operable, HER2 positive operable, we still give neoadjuvant. So look at a pathological here. So here we are looking at a total complete response or a major pathological response. So that's the more important thing.
Yes, sir.
So you talked about the CTRE toxicities, but you saw one of the presentations from 4% to 11% of mortality. So once you are counseling a patient, so how many will agree that? So in one side we are talking about a morbidity which may or may not happen because there are so many. And you know that, so that become more important. And these days with better radiation technology, so you don't get much. And those who are smokers, probably you get more of them. Otherwise, a non-smoker with good performance status. So during your counseling, so how many, so if you say some 4% to 11%, it varies according to different centers. So how many will agree to surgery?
So coming back to what regimen you are going to use, you said checkmate 816, which means you are presuming you are not going to offer the patient a perioperative approach, right? No. So we heard those lectures, right? So if you are going to use neoadjuvant or adjuvant immunotherapy, there are now 6 or 7 trials, right? You have the 816 was just a neoadjuvant trial. You had the adjuvant trials of Atizo, Empower 010 and the Pearls Keynote 091. And then you had 3 large perioperative, right? Checkmate 7070, AGN and Keynote 671. So by saying that you are going to use the 816, you have taken a decision not to give post-operative immuno?
According to the trial, adjuvant chemotherapy is the option and no immunotherapy in the adjuvant setting.
No, I understand. So you are giving the chemo immuno now, but in all of the other 3 trials, the immunotherapy was continued. So that's why I'm asking, what is your basis for deciding that this patient needs only neoadjuvant immuno and not adjuvant immuno? It's okay, it's very simple.
So
Cost,
financial
right?
toxicity because
Cost.
of treatment. Yes.
Yeah, that's fine. So that is the advantage of having just a neoadjuvant approach, that you are giving a finite number of uh, immunotherapy cycles, and therefore considering the overall cost of these immunotherapy drugs, it is a reasonably fine decision based upon patient resources and everything.
What did you do finally with this patient?
Sir, we have offered him a neoadjuvant nivolumab with platinum doublet based chemotherapy followed by surgeries.
Coming to that same thing now, so why do you think that what is the dose of neoadjuvant, what is the dose of nivolumab used in this? 360 mg? And what is the approximate cost of 360 milligrams?
3.7 lakhs or something.
Right. And so for if you are going to use it for 3 cycles, it's going to be close to 10 lakhs, right? And suppose you use pembrolizumab.
So it's 200 mg 3 weekly, sir. It's coming to 3.1 lakhs, sir. As of
And the third drug,
Atizo is 3.5 lakhs something.
they don't have a trial for Atizo in the neoadjuvant setting.
No, sir.
It's durvalumab.
Durvalumab.
Hmm. Okay.
Suppose patient not opted for surgery, then what is the approach? He doesn't want to surgery, he is medical unfit. Then how you will manage? What is the details? What is the chemo? What is the maintenance? What is the adjuvant?
Radiation dose is usually 60 to 66 grade 30 fractions, and chemo either BP60 with cisplatin or BP paclitaxel carboplatin.
As per institution policy, sir.
What is? Just tell loudly.
As per institute policy, sir.
So what is the options? What is the other options?
So what are the chemotherapy options? 1, 2, 3.
This is adeno, right? So
Yes,
you can
sir.
use some other drug also.
Pemetrexate, carboplatin.
And that has been compared in a phase 3 trial, right? For
Yes,
as part of a concurrent chemo radiation regimen, and found to be just as good.
Followed by, sir, adjuvant durvalumab for 1 year. As
What
per
is the advantage? What is the data for?
Pacific trial, sir, it has disease-free survival as well as overall survival benefits.
So when do you consider Pacific? So you have finished off CTRT today. So what will be your criteria? This patient will go for a Pacific.
Sir, non-EGFR, non-ALK, sir, as of date.
Okay.
And irrespective of PDL1 expression, sir, they
Okay.
did well.
Third point is important. So what is the response at the end of CTRT?
Yes, sir.
Suppose it is at the end of
progression
CTRT is a
after
progressive
CTRT.
disease.
Yes, sir. No progression
Right.
after
So
completion.
it has to be CR, PR or a stable disease. So if it is a progressive disease, then he doesn't go. So anybody a candidate for induction chemotherapy before you put the CTRT. So any case, suppose this was not a 3.2 centimeter, it was just 7 centimeter disease. So rest remains same, it is 7 centimeter disease. So in the original trial, so there were a good number of patients who were on induction therapy. So they received 3 cycles of chemotherapy, then CTRT, and then they were into the Pacific. So when do you start the durvalumab maintenance? So all criteria fulfilled. So when do you start? So what was the stretch?
8 weeks, sir. 42
Right.
42 days post completion.
So you wait for what? So if the patient has a radiation pneumonitis, so you wait till the patient has settled down, right?
So this patient either way went for surgery or did not go for surgery. Never smoker, and you have tested EGFR by RT-PCR and ALK by IHC. Would you consider NGS testing? Number one, if the patient underwent surgical resection on the resected specimen versus the pre-op specimen, and if the patient did not undergo surgical resection on the diagnostic specimen. If yes, why, and if no, why not?
Sir, as of date, for a better planning of treatment on the biopsy specimen,
Which Specimen. So the patient who undergoes surgery?
For the patient undergoing surgery, I would do on the surgical specimen, sir, because it takes care of the tumoral heterogeneity, better analysis of the sample.
For a patient who has been exposed to neoadjuvant chemoimmunotherapy?
No, sir. Upfront surgical we would do on the surgical specimen, sir. For a person who is underwent a neoadjuvant chemo or immuno, we would do on the biopsy specimen.
The initial one?
Yes, sir.
And suppose that was a small biopsy, not adequate for further testing, then?
Sir, a liquid biopsy can help us, sir, if there is a sample inadequacy.
So liquid biopsy you are going to do as for testing for oncogenic driver alterations or as a part of MRD monitoring?
So MRD right now is, sir, in part of trials only as of date, but there are encouraging results. But for driver analysis, we can do it, sir.
And suppose you find a RET fusion, then what are you going to do?
So as of date, sir, for other than ALK and EGFR, there are no targeted therapies approved, but there are some trials going, sir.
So the next question which the patient can ask is that if you are not going to do anything, why do you test?
So better prognostication and planning future.
So sir, whether you know whether there is a RET or you don't know there is a RET, for a patient who has undergone surgical resection, how does it matter? No, so the answer is very simple, that you do not know the results of molecular testing till they come in. You cannot predict.
Yes.
And based on just the prevalence of current oncogenic driver alterations, the most commonly detected oncogenic driver is still an EGFR, which may have been negative by an RT-PCR simply because an NGS is more sensitive than an RT-PCR.
Yes.
So that is your argument for testing.
Yes.
You don't know the results till you have them. Okay, I think we are out of time.
Thank you.
Thank
you so
you.
much.
Thank you so much, sir, all the faculties.